right, so let's talk about PCSK9s. What is their mechanism of action? How are they different, for example, than statins?
Sure. Statins prevent the production of cholesterol and also down or upregulate the LDL receptors to an extent, but that's not their main mechanism of action, whereas the PCSK9 inhibitors actually simplistically inhibit the degradation of the LDL receptors, so there are more receptors available to clear the LDL from the blood.
Okay, so it's an entirely different mechanism of action. And as I understood the statin drugs, they actually sort of turn the liver into an LDL vacuum cleaner. There's a lot of reuptake going on. And that's not what's going on with the PCSK9s. So we know over the years about the safety and efficacy of the statins. We pretty much established that. These are new drugs, and there are two of them out there, right? Evolocumab, I'm going to try the next one too, which is alirocumab.
Yes.
So why don't we compare the efficacy and the safety of evolocumab first? How good a drug is it? How safe is it? What does it do to your cholesterol?
Well, the studies were based on, and this is key, this is going to come up when we talk about some other things, is that it's on top of standard of care, which includes a statin. So that's the key.
Okay.
So they significantly lower LDL. And I think the average is in the 4-year study was down to like 30 or 35, something like that. So pretty significant
Just
LDL
stop
lowering.
right there.
Yeah.
That number of and by itself should cause all of our viewers to just take a deep breath. I mean, we are struggling with statins often to get the number down to 110.
Right.
190, especially if they're genetically driven. And you're talking 30? 30?
Right. Yeah, but the challenge though, the statins are great drugs, and they're very cost effective. And with some of the newer higher potency statins, you can get a 50-60% reduction, but you've got to titrate the dose, and you've got to do other things. And that's also part of the challenge with the statins, is we've talked about the silent nature of the disease and compliance issues, but part of it is lack of titration, and so we're not maximizing the benefit of the statin.
But let's even talk about a 50% reduction. If somebody starts out with an LDL cholesterol of 220, you're going to get it down to 110. Right. 110 is not good enough.
Yeah.
Right.
Right. So if we're talking about, but it's different if you're talking about somebody with an LDL of 90 versus an LDL of 190, and then what the other risk factors are and what the other comorbidities are. Okay. So I don't think you can, completely answer it across the board. But yeah, these drugs are extremely efficacious, and evolocumab now has published outcome data, which we'll talk about. We're waiting for the other drug.
Okay.
So the question is it class effect or not? We're probably assuming at this point it's class effect, but they have shown a significant reduction in the composite endpoint of reduction of events. But interestingly enough, within that, so the primary endpoint in that study was MI, stroke, cardiovascular to death, rehospitalization due to unstable angina, and I think one other thing. The secondary endpoint, and that was statistically significant. The other interesting thing, though, is the secondary endpoint only looked at a subcomponent of that and looked at each individual driver of the composite.
Okay.
And death due to any cause or cardiovascular was not statistically significant. So it was just, so there is a significant reduction in LDL. There's a reduction in stroke. There's a reduction in MI. All great things. But there is not actually
But Jeff, that was over a 2-year time frame, right?
Yeah, it was 2 years.
47,000 patients at large, but only over 2 years.
Is 2 years powerful enough? Is it long enough?
Well, I think, if you look at the absolute risk reduction, it was modest. It was 1.5%. So if you think about numbers needed to treat, you're thinking about 67 patients that you have to treat to prevent one event. So I look at the outcomes, especially the cardiovascular outcomes, as being more modest. And then if you think about the Improve It trial, which was also recently done with ezetimibe, then those patients, a little bit different population, those patients actually had ACS, but adding ezetimibe to a statin had a somewhat similar absolute risk reduction in cardiovascular disease. So now we got kind of 2 studies out there that are playing kind of a role in deciding, well, which way do we go with drug therapy here? And in the ezetimibe study, you didn't see the profound LDL reduction that we saw in the other study. But I think, again, it comes back to the point that it was only 2 years, stopped after 2 years. What would have happened if it went 5 years? Because I think that's more traditional with cardiovascular outcomes.
I like your point on the Improve It trial. It was a much longer trial to show that benefit. But the FDA actually rejected their claim to add reduction in cardiovascular outcomes to their labeling with the same modest reduction. But if we see longer trials on these like we do on most cardiovascular drugs, 5 or more, I do think we'll see more benefit. We just haven't seen it yet.
I remember the original Nissen data when the statins were coming out. Nissen kept showing there was no floor below which you, A, couldn't lower LDL cholesterol to B, show an improvement in cardiovascular profile. So if you're telling me that after 2 years you don't see this, where's the disconnect?
Well, I think there's still a log linear relationship. I mean, the lower the LDL, there's been no J-shaped curve or anything like that we see in hypertension. So the lower the LDL, the better. I still think that plays a role. You know, these patients in these studies were already very well controlled. Their LDLs, for the most part, were less than 70. They were already on statin therapy, and some people debate the issue about, you know, the lipid amount in the atherosclerotic plaques and so forth as to whether that could affect the efficacy or not.
So if we say, oh, go ahead. Yeah.
Well, I was going to say, I don't want to discount. I don't want it to come across that I don't think these are good drugs. These are really good drugs. To show a reduction in MI and stroke in 2 years on top of standard of care, on top of a statin, is fantastic.
Absolutely.
I mean, that's comparable to what we saw with NOACs and antiplatelets. I mean, significant reductions in events and medical offsets. So that's usually important. But when you talk about numbers needed to treat and evidence-based medicine, that gets back to your editorial, is at the price of these drugs, does it make sense now to have everybody with elevated cholesterol on these drugs, or do we follow the guidelines and the study design and try to find those patients who are at risk or where we have data to say that these drugs are going to be effective?
All right, well, what about, if we're all talking about how efficacious these drugs are, and let's use efficacious in the most unscientific way, that is that they're going to dump your LDL cholesterol, and we'll wait a few years and see if that's really clinically significant. Now we have to talk about the risk. What are the clinical pharmacologic risks of these agents? Where do we even start?
Well, I think, in this study with the LDL being reduced down to 30, I think there's some concern about neurocognitive effects of that, and at least in the study that we've done here, and there's an extension of that study going on now where they're actually looking at that a little bit longer, the neurocognitive effects of having the LDL that low, but at least in this 2-year study, there was no effects of it. Also, one of the bigger concerns with statins was, does it cause diabetes? And there were no cases of diabetes found with this as well. So, those are two promising things, and I think maybe the most common adverse event was injection site reaction, so it appears as though they're fairly safe.
All right,
Yeah, more tolerability rather than safety. The only other probably question is, these are monoclonal antibodies, so are we going to have neutralizing antibodies, and what does that mean from immunogenicity? But that's not I don't think it's a major concern, but it's another unanswered question.
I did ask you specifically about avocilumab, right? But what about alirocumab?
Alirocumab.
Yeah. What about that one?
Alirocumab. On the label, there's the lower strength, so there's 75 milligrams. So we have seen some criteria that starts the patient first at 75 milligrams subcutaneously every 2 weeks, and then measures control, and then there's a dose escalation from there if the patient needs it.
All right, but that's all? I mean, the side effect profile is the same, and as far as you can tell, the efficacy
Pretty
is the same?
similar.
Yeah, very similar.
Really? Okay,
Very well tolerated.
Then what are the approved indications for these drugs, which is what we've been dancing around, this little 800-pound gorilla in the room.
I think Jeff addressed it a little bit in that this is, even in the labeling, in addition to maximally tolerated statin therapy for familial hyperlipidemia. Evolocumab also has a homozygous familial hyperlipidemia indication for its 420 milligram monthly dosing. But otherwise, the indication is the same for both drugs.
And it's ACSVD. It's not elevated cholesterol.
Okay, we define that, ACSVD. This is not
atherosclerotic cardiovascular disease. Yes.
CVD, cardiovascular disease. All right, and we got to ask, what do these drugs cost? What are we talking about spending? I mean, you've already mentioned that the cost of statins is so low now that you're not even worried about it.
Right. So the cost is, on average, anywhere from $1,200 to $1,500 a month. There are rebates and other things associated with that, but that's the WAC, or wholesale acquisition cost. So you're talking $14,000 to $15,000 a year. So relative to a lot of other specialty drugs that we've been dealing with over the last 5 years, that's not a big deal. I mean, we have drugs now that are $200, $300. We even had one drug now that was $800,000 for the first year that was recently launched. So, but the issue is the size of the population. Those other drugs are orphan diseases.
Okay.
So this is, if we talk about a third of the population that has elevated cholesterol, or whatever the number was that we talked about, you apply now $15,000 times that number, that now would be the number one by far budget impact item for any payer.
It's also, by the way, if I may just point this out, just because I sound like a mother saying, if everyone else jumped off a cliff, would you jump off the cliff? Just because all the other drugs out there that we're comparing this to are really expensive, doesn't mean yours is cheap.
But here's the challenge though, is if you look at data between 2012 and 2018, there's going to be a doubling in what we are spending on medications.
Okay.
Now think about that. In 6 years, we've now doubled what we're spending on medications. So the average per member per year is going to be next year $1,700, $1,800 a year. So there's a limited amount of dollars. So if we go to an employer group, and let's say they're self-funded, and it's their dollars, and now they have one hemophilia patient, or they have 20 patients on these drugs, the impact to them is huge.
Well, of course it's huge.
So it's not, I don't think you can compare an oncology drug to this in terms of cost and all of that, because those are significantly higher, but it's the prevalence. So you have to combine the two in understanding the impact to the system.
But the prevalence, if we truly look to label to patients who have atherosclerotic cardiovascular disease or familial disease that is uncontrolled by statin therapy, then we're looking at $1 million in the U.S.?
1 million times 1,400 per month, whatever. All right.
And there's maybe it's just payers being unnecessarily worried, but whenever we have a drug, a very expensive drug, enter a large space, whether it's asthma or cardiovascular disease, or even Hep C, we assume the worst because we have to. That's our exposure. So it gets down to you mentioned denials and other things earlier. It's about the appropriate patient. I have no qualms in paying for this drug in the appropriate patient because we will see a benefit.
Okay,
the
so why
question
don't we
becomes then, if they don't have ACSVD and they're not on a statin, we don't have evidence to say we're going to have a non-LDL benefit, so where do we go with it?